See you soon.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone, and welcome once again to CARN's Health Hour. My name is Dr. Vanessa Rapier. I'm a consultant in sexual health and HIV, and I am your host today. And as ever, I love welcoming our regular listeners and our family and networks. It's great to have you here again. And also, I really want to welcome those who are spending time with us for the first time. It's really great to have you here. So, who are we? What are we doing here? So this is a health hour initiated by CARN, and we're really here to bring health education to your fingertips. It's a platform in which we want to reach people where they are, to support you to take control of your health, and also to support you and your family members, your friends, your colleagues, to really live your best life in health. And what is specifically bespoke about what we do is that it really is targeted at Black communities, and it is brought together by and curated by the Caribbean and African Health Network, CARN, who bring together Black healthcare professionals globally, really, to come and provide you with the information that you need for your health. As ever, it is a conversation for you, and you are here to listen, but you're also here to engage. And so please feel free to ask any questions that you have, put them in the chat whilst the speaker is speaking, and then I'll make sure that we go through them at the end, and I'll really try to go through as many of them as I can. And if we feel that we haven't got through enough of them, then there will be an opportunity in which we'll give you an email that you can contact, and we'll also share the information as well. We are recording live, which is fantastic. And that means that we are on our platforms of LinkedIn and YouTube. So it really means that if you're watching today and you think, right, this is fantastic, I want to make sure that other people can watch it again, it will be on those platforms so people can access them at any time at their leisure. So please do share the link. it would also be great to really hear about where you are in terms of your location around the world. I'll let you in on the world's worst secret. I'm actually in Ghana at the moment, presenting to you here. So it's great to be here. So it'd be lovely to hear where you all are. And also, if you're watching alone or you're watching with friends or family, we love hearing what you're doing this morning. Just to note, and please be aware that we are recording, as I said. So this is why we've essentially kept cameras off largely. So just so you know. And without further ado, I really want to introduce our fantastic speaker today. And we don't take it lightly that we have her here today. And we have Miss Ijeoma Chibuzo. Now, I hope I've said that right. I practiced earlier, and I thought it was important to say it. And you're probably smiling out of kindness, but I hope I did. But what is fantastic, and I really want to highlight this, is that Miss Ijeoma is a consultant neurologist in Nigeria, and this is no mean feat. She is one of 7 only in the country, and she's the first to be with the National College. And so we first of all want to highlight and give you the kudos that you deserve for such a milestone in your career, and it's really, really powerful. And we're all also really blessed to have Miss Ijeoma working in the UK as well, at the Royal Bolton. So straddling her expertise in Nigeria and the UK, and also sharing it with us on the Health Hour today. So thank you so much for being here. And we are going to be hearing about prostate cancer. And I think this is a topic that many of us will have heard the name and will know a bit of it, but how it affects the men in our communities and the other information that we need to know around it. I would say that our awareness isn't where it should be. So we're really honored to have you today. So Miss Ijeoma, over to you.
Thank you. Good morning. I am so happy to be here. Thank you for the invitation. So without much further ado, we're going to be creating more awareness. And this is a topic that really cannot be overemphasized. So I'll just share my slides with you. Right, I hope you can all see that clearly.
Yes.
Okay, so what we need to know about prostate cancer. We're going to talk briefly about it, and I'm looking forward to hearing a lot of questions. So let's engage you. Let's get the awareness out. So mostly it's going to be around screening. And then when we discover that the person has prostate cancer, what happens next? It does not spell doom, I promise you. So these are the things that we're going to talk about. But given that this is for the community, I find a lot of patients, when I'm explaining to them about prostate cancer, rather than asking me about prostate cancer, they're saying, but what is the prostate? So I thought, let's start from there. That is a good place to start, and we'll work our way upwards. Some of you might know this gentleman. This is Mr. Colin McFarlane, who's a great advocate for prostate cancer. He had his diagnosis in 2023. He's a TV anchor. He has been on different shows in the UK, and he was diagnosed early. He had his treatment, and he's here saying, let's start from there. What on earth is the prostate? So a lot of people might know about a little bit of anatomy. So the bladder is what helps us pass urine. Underneath that, in men, there's a walnut-sized organ, which is the prostate, which is quite important in getting the semen to be fertile enough. However, as men grow older, it gets bigger. And as it gets bigger, what you can see here is that it is able to block off urine. But in addition, it harbors cancer in some cases. So how is every problem with the prostate cancer And that's where people get it wrong. Not everything about the prostate is cancer. Sometimes it's what we call a benign disease, and sometimes it is cancer. Now, it just depends on where the problem is. I've drawn a little pictorial diagram showing the prostate in different parts. Now, this is what we call the peripheral zone, and that is where the prostate cancer lies. Most of the time, when there is a problem in this other parts, most of the time it's a benign problem, giving them issues with their urine symptoms, yes? But where the problem lies with prostate cancer is this place, mostly. Now, prostate cancer is the second most common cancer in the UK after lung cancer. It is the most common cancer affecting the male population. In the UK, we have up to 150 new cases every day. The statistics will vary as to what number it is in terms of causing death. In Europe, it's about the third. I think Brave said it's about the fourth worldwide. But more importantly, I'm going to cone down to how it affects people of different races. Now, if you can see this slide, this is where it gets interesting. Normal statistics we hear will be that 1 in 8 people would have a new diagnosis of prostate cancer. But you can see in red here, 1 in 4 Black men in their lifetime are at risk of developing prostate cancer, which means that is twice as high at least. Of course, it's less in the Asian men. So fine, developing prostate cancer is one thing, but then what happens after the person has had that diagnosis of prostate cancer? What is the risk of dying from it? In the whites, 1 in 24 people might die from it. But can you see this value? It's higher in Blacks once again. So 1 in 12 Blacks can die from it. And this is just telling us how important it is, because we are having so many new cases every day and about 12,000 deaths just in the UK. Worldwide, it's higher. Now, I'm going to cone down to how things work in the UK. If one suspects they need medical care, they generally go through the GP. So I've put up this slide to show us the incidence of prostate cancer in people presenting to the GP practices. The Blacks are in yellow, whites are in blue, and the Asians are in green. And if you can see that from the age of 40 up to just less than 80, Blacks still have the highest incidence of diagnosis. And this was a beautiful study done by various centers in the UK. And it's just further highlighting that from the ages of 45, you're having a much lower incidence in the whites and higher incidence in the Blacks, and it keeps going. And the margin of that difference keeps rising. So they said that Blacks are 3 times more likely to have prostate cancer, but yet I come in contact with patients who have not had a PSA at certain ages and seem to be oblivious of their risk. The good thing about the study is that it said, if you're detected early, the difference in survival in the UK is the same. And as you can see in this slide, I'm showing that in the 80s, almost everybody is having the same incidence. It pans out. Now, this slide is interesting because blue is diagnosis. And you can see the diagnosis is actually higher in Northern Europe and least in Asia. And the African and Caribbean nations come in between. However, on the red side, that is people dying from the disease. And unfortunately, highest mortality rates worldwide, Southern Africa, Caribbean, Middle Africa, Western Africa, Eastern Africa. So Caribbeans, Sub-Saharan Africa, we're having high mortalities. So why is the story different in Blacks? Is there something we can change? So there are things we definitely can change. We can't change our genes. So Blacks have been found, or there are studies still going on to decipher why our genes are different. But it has to be something with the androgen receptor, because prostate cancer feeds off testosterone. So HPC, BRCA2, all those genes, we can't change all that. However, what can we change? And this is where it gets the This is where we take responsibility. So there's something called delays in presentation. We've got type 1, type 2, type 3 delays. Type 1 delays will come from the person themselves. How often does a Black man take himself to the hospital to say, I want to get myself checked? Because a lot of times, especially in sub-Saharan Africa, you'll find that they keep putting it off until they develop symptoms. So modifiable factors, come early to the hospital, let it get checked. Some people get a diagnosis and then they are worried that if they get treatment, they have side effects. And a lot of times I hear patients worried about their erections being affected by treatment or sexual function in general or incontinence. So you hear that a lot. I remember there was this interesting paper about whether or not men would want to choose survival over their erections. And it was just a survey and they chose their erections over survival. So it's that kind of thing. But there's so much that can be done for such side effects if they happen. Of course, we know that there are racial disparities in different areas as to how Blacks access healthcare. There was a paper from America saying because of insurance and financial constraints, the Blacks definitely do not have as good access as should have been. Of course, in sub-Saharan Africa, we also have the financial issues and the fact that in certain areas, people pay out of pocket. So that makes it difficult. So those are modifiable things, but those are why Blacks have a different picture. In the general population, what increases the risk? As people grow older, they're more likely to get prostate cancer, which is why we say, as you're getting older, get the checks done. Get the checks done. So what I'm saying here is it has shown that less than 5 out of 100 people in their 30s can have prostate cancer. But as you get older, you're getting 1 in 2 people as you're going towards 80. So as you're getting older, the risk increases. If there's a family history, the risk increases. And when I say family history, if a father has had prostate cancer, 1 is 2 times more likely to get prostate cancer. If a brother has had prostate cancer, 1 is 3 times more likely to get prostate cancer. If a mother has had breast cancer, then that also increases the risk. There's a particular case I remember. Sister had breast cancer and the man was diagnosed at the age of 45. And unfortunately, he came with metastatic disease, a young Black man. So these are things that we need to know that these all increase our risk. Ethnicity, I have emphasized. There are so many papers saying other things that increase risk, but these are not really as proven. The first 3 I mentioned are the most important. What can reduce the risk? That's where most people are so interested. Are there things that can reduce the risk? There are studies like the Reduce and Prevention of Prostate Cancer trials that show that there's a 25% reduction in patients on finasteride and dutasteride. But overall, examining all the evidence available, there is no actual prevention of prostate cancer. So the key is early detection and treatment. So how do we know that there's a problem? I think that's one of the places that people get caught out because they're waiting for symptoms to present for therapy. No, early cancer has no symptoms, which is why we advocate population screening rather than opportunistic screening. And I'll explain. Opportunistic screening means that you've already started having symptoms and then you go to the GP and get a PSA check. But I am advocating going without having any symptoms because that's when we can get it early. Of course, problems with urination, people start having increased need to pass urine. There might be some blood in the urine. There might be late features. Now, if a person starts having features of spread of cancer, this might include back pain. In sub-Saharan Africa, we tend to find farmers thinking that they are just having back pain because of the work, but meanwhile, they've been harboring metastatic prostate cancer. It could spread to other places. Spread to the lungs and the liver is not really as common. And if that happens, it's not a good type of cancer. But like I said, the moment one starts having symptoms, it might not be as early as we would like. So one has got to the GP, either just for the PSA checks or because there are symptoms. What gets done when we get there? The GP would take a history. They would want to examine you, and that might include an examination of the prostate. That examination of the prostate will involve a little finger being put through one's back passage to feel it. Sometimes that doesn't get done, but they will also do a blood test, which is a prostate-specific antigen test. If that shows it is high or the prostate examination is abnormal, they would initiate a referral to a healthcare center for you to see a urologist, and that's where we come in. And when that happens, there's something we call a straight to test pathway, which is the main thing that's going on now. We're trying to get it right the first time, and we're using MRI pathways, rapid access. So you will go straight to have an MRI, which is a magnetic resonance image of your prostate that can look closer at what is happening with the prostate. And if we feel it is necessary, we will get a biopsy done. Depending on what we find, you might need further tests. And that might be a CT scan, a bone scan to look for if there is spread of the disease, and in some cases, more advanced scans. Now, this is where a lot of people have questions. They say, oh dear, my PSA is high. Does that automatically mean I have cancer? It doesn't automatically mean that, no. But it increases our suspicion. And when I say it doesn't automatically mean that, yes, it's a guide, but there are other things that can cause a raised PSA. But I don't want you to make that decision yourself. See your doctor. So an infection can cause it. Recent ejaculation can cause it. Avid cycling can cause it. Other granulomatous diseases can cause it. Cancer itself can cause it. So there are different things. See a doctor. They will make the difference. Even a benign enlargement of a large prostate can cause it. Now, this is just a guide because I have so many GP colleagues who sometimes have beautiful questions about this. And this is just a guide. And this is by the EAU. And we adopt it generally in the UK that when PSA is above 3, send over and we will fish out if it is cancer or not. There are some other things that we look at. There are age-specific cutoffs in terms of PSA. So we expect that a younger person will have a lower PSA, but we still have PSAs that are low for an elderly person, but they're abnormal for a young person. So we look at that. But to avoid any confusion at the GP's level, we just say, this is the blanket thing. Send when it's above 3. And then when the person comes to us, we will assess the risk and know if a biopsy is needed. A biopsy is a little test that will take samples of the prostate to see if there is cancer. This is a shout out to my Nigerian colleagues in Ibadan. This was us doing biopsies on patients. And this is just commonly around the UK, we've moved to transperineal biopsies, where a little probe, like an ultrasound scan, is put through the back passage. And then you can see that that's the prostate there, and that's the bladder. So we can take biopsies from there. We tend to do it under a local anesthetic. So you're awake, you're chatting, but we've numbed the whole area, and we can take good biopsies that we can end up getting a diagnosis. If it is prostate cancer, it doesn't have to be a death sentence. Early presentation, a lot of it is curable. Early presentation gives good prognosis. So we have different options when it is early. Sometimes we might say we're just going to watch it because it might be a low risk cancer. So we don't have to do anything. We just monitor your PSA and make sure it doesn't transform into something more significant. But sometimes we say, no, this needs to be treated. And there's something we call a radical removal of the prostate, where if that's the prostate and that's the bladder, we will take out the entire prostate and connect the bladder to the urethra. So the element of cancer is gone, and we take out the surrounding things that can also be affected by cancer. Okay, so The other thing we can do is refer for radiotherapy, in which radiation is given to treat the cancer. So they don't do any surgery, but then they'll follow you up to make sure your PSA has fallen and that there are no adverse symptoms. There's nothing without risks. And that's where a lot of Blacks I've discussed with start getting worried. So yes, with surgery, you can see these are nerves. So we're aware that those are there. If we can spare these nerves, because these are nerves that are important for erections, for ejaculation. When we do this surgery, unfortunately, we will take away the ability to ejaculate. So the person won't be able to produce sperm because we're going to cut the vas, but we can preserve the erections. And then there are so many things that we do. We call it penile rehabilitation to preserve the erections after surgery. So that should not be a reason for not coming or not getting treatment. Yes, when we join this up, there is a muscle that keeps us dry. So that might be lax or injured temporarily. So there might be some urine leaks, but we also teach you pelvic floor exercises. So that makes you gain your continence back. Sometimes after a year, there might be a need for something else to keep you continent, but a lot of people tend to be relatively dry at 12 years. Now, these are early. By the time it is late, we're now talking about managing the disease, managing the symptoms. We're no longer talking about curing the disease. And that is where we don't want people to come. If you come, we will attend to the things that need to be attended, but the outcomes are much better when patients present early. Right. Common questions I get from patients. What can I eat to prevent it? If you remember the slide, I said, there is no study that truly proves that these things prevent it. But the good news is that some of the non-modifiable risk factors may be modified. So some things that we can do not to prevent it, but to improve the prognosis. So there was this beautiful study that was done in about 12,000 men, health members of staff. And they followed them up for up to 27 years. 3,000 developed prostate cancer. So they now looked back to see what they were doing differently in terms of who did better prognosis-wise. And they found that they had better outcomes despite the fact they developed prostate cancer, but those who had a good lifestyle. So they exercised regularly. Their diet had less processed food, more fish, less dairy products. They quit smoking more than 10 years ago, or they never smoked at all, and their BMIs were less than 30. So those are important things. There were some studies that showed benefits of some food stuff in reducing mortality and improving prognosis, even if you develop prostate cancer. So these are some of the foodstuffs: tomatoes, carrots, lycopenoids, and carotenoids. Of course, there are some studies that will tell you that polyunsaturated fatty acids help. And then I've already mentioned these, yes? So another question I commonly get is, I want to prevent this disease, so I want to take out my prostate. That doesn't work because nobody's going to do such a big operation if there's no cancer, because no surgery is without risks. So some of them might say, okay, I've had surgery on my prostate for a benign disease. So that means I must be free of the ability to develop prostate cancer. That, once again, is not right. And that's because if you remember the picture I showed you of where prostate cancer develops, maybe I should go back to that slide and that will make it better. So prostate cancer, more of it is here. Now, if we do a surgery for benign disease, this is what we take out. So it means that one can still develop prostate cancer, so should not let down the watch and still keep on checking to see whether or not, so still do your tests, yes? And this is where there's a lot of controversy. So there's a lot of information going around saying if you ejaculate more, you reduce your risk, but there are not enough studies to support it. There's a Harvard ejaculation study, which stems off of the lifestyle study. And they found that when they looked back, some people who ejaculated more had less risk of prostate cancer. And there's another one in Australia. But we don't have enough studies to say that. So people now harp on those and emphasize it. But up till now, we don't have enough evidence to say these are the preventive things. So right now, we emphasize get screened, get early detection, get treatment early, and look out for your risks. So if you have a family history, get screened earlier. Be vigilant. That's what we're saying. We're saying we want to change the narrative. Men of African descent were studied across countries in Africa, and you can see such high mortalities. Now, in the studies I showed you earlier, it's diluted by white population, Asian population, but this is just studies in Black men. 61 out of 100,000 dying. These are too high. We need to change the narrative. We need to come early. We need to get diagnosed. Financial constraints. In the sub-Saharan Africa, we might not have MRIs in every center, but we do have a PSA. We have a DRE. So we should use our resources available and get diagnosis early. And I want us to change the narrative to these. These are Black men. Some of you might know some of the pictures who were diagnosed early. Sidney Poitier. He was diagnosed, lived 30 years after, died from something else. Harry Belafonte, same thing. And Black men came early. Black men got diagnosed, and I want us to spread the word. Now, my take-home message is the guidelines will state any man above 50 needs to get a PSA check done, okay? If the person is of higher risk, men of African descent or family history, from 45 years, they need to start getting their checks done. And of course, if they have positive genetics showing that they are really at risk, from 40 years. So most Blacks will fall here. So if you know you're 45, you've not had your PSA checks done, start today. Just remember that if there's nothing else you remember from this discussion, go meet your GP, go meet your doctor, get your PSA done. It is curable if it's detected early. Don't wait for symptoms, but if you have symptoms, don't think of it as a taboo. Get seen by a doctor, all right? Let's differentiate between prostate cancer and benign. Don't assume that because your friend's issue was a benign prostate enlargement, yours is. Everybody's an individual. And I shall wait for your questions. Thank you.
Thank you so much. That was fantastic. And I love how you ended it there, in terms of not to listen to what your friends' experiences are, because I think that is such a common reflection, and we'll talk about it more because there's some related questions about that. But where someone's assumed that their friend had it and they went late and it was all fine, so there's no problem. We're all individuals. So thank you so much, and thank you so much for making it so clear and succinct. And as ever, we have questions coming in thick and fast. So I will bring them to you. So just to start off with one of the early questions, actually, and just again, someone's written to me personally, just saying, thank you so much for explaining what the prostate is. Sometimes it's so that the person's written didn't want to ask, but thank you. So another person's written, is it right that the prostate increases in size as all men grow? And if so, most, if not all men will eventually have minor to severe cases of BPH, I'll allow you to explain that, or worst case prostate cancer. So does it increase in size in all men, and will most men have some kind of form of enlargement of their prostate?
Okay, that's a lovely question. So yes. Now, I love how the person has once again highlighted that the prostate can have different issues. So they mentioned BPH, which is benign prostatic hyperplasia or hypertrophy. So we're just trying to say that the prostate is enlarged, okay? And that is benign, it's not a cancer. So because the prostate gland, I'll start again. There's a male hormone called testosterone. So the longer it is exposed to that, it increases in size. So as the person has more years in life, he has more exposure to testosterone, so it increases in size because it's being fed by it. Now, the fact that a prostate increases in size does not translate to symptoms. So some people might have a smaller prostate and they're having loads of urinary symptoms that make them come. And some might have a larger prostate, but they're not having any symptoms. But it doesn't mean it's not growing. That's one distinction. The fact that it increases in size does not mean one has cancer. Okay? So yes, it increases in size as people grow older. Yes, that means as people grow older, they are likely to have symptoms from an enlarged prostate. And as I mentioned, yes, as people grow older, they are likely to have more prostate cancer, which is why in the very elderly, at some point, we stop checking because it's likely going to be there. So some places will say above a certain age, no more PSA checks, because we know we're going to find it. Remember, I said at point it gets to 1 in 2 will have prostate cancer. But prostate cancer does not always kill. So in the elderly, sometimes we just watch it. We call it watchful waiting because something else will get them before prostate cancer.
Mm-hmm. Thank you so much for highlighting that, I think, as well, in terms of, because you have, as we've said, like some people will delay in engaging and testing. And then some people will think, oh, I want tests all the time. And why is it now that I've gotten to this age that you're not bothering about me? So I think it's really, thank you for explaining that. And so you've answered this, but I think I like it that someone's mentioned it. So important for you to emphasize. So someone said, oh, should men wait for symptoms or ask more proactive questions in health checks and screening?
So I love that question because once again, I'm going to emphasize, we don't want you to wait for symptoms. Mm-hmm. Okay, so we are saying, come, get checked, visit your GP, visit your doctor. Black man, 45 and above, make sure you get checked. General populace, 50 and above. Strong family history, definite genetic predisposition. Maybe somebody has had breast cancer and they found out it was BRCA2, which is a gene that is really not great for cancers. Get checked from 40. Father had prostate cancer, get checked from 45. You're Black, get checks from 45. So don't wait for symptoms.
Great. Thank you so much. Another question, a more specific question, and good to prompt the conversation, is that if someone from time to time has, and again, we'll allow you to explain it, please, occult blood in the urine and cystoscopy is done, but you do not urinate blood, is this an early sign of prostate cancer?
So now, I'm loving these questions, I have to say.
I know, they're always great.
So now, occult blood in the urine, sometimes we call it, when you submit a urine sample, they would now do a dipstick and then they'll come up, oh, there's blood. So that can mean a multitude of different things. So the first thing is they will make sure it's not just the one-off. So they will do it more than once. And then, I was thinking, what are the possibilities? It's a non-specific thing. It can be an infection. It can be a cancer in the urinary tract. When I say urinary tract, that's a bit vague. So it can be a cancer in the bladder, can be a cancer in the tube connecting the kidney to the bladder, it can be a cancer in the kidney. It might not even be a cancer. For example, if people have a big prostate, it's quite vascular, so it might bleed. So they will have a dipstick test, but it doesn't mean they have cancer. So it doesn't mean they have cancer of the prostate. So I would not equate occult blood to cancer. I would say occult blood, get it investigated so that we can determine what is the cause.
Mm-hmm. Thank you. And I like this one as well, just because particularly being in Ghana and hearing lots of the different remedies that people use for different parts of their health and wellness, which you know, I acknowledge and embrace. And someone's put, I've heard that soursop may support prostate health. Could you kindly confirm this?
Right. I can't confirm it, unfortunately. So I think what we need to understand is sometimes some people give accounts of how a particular thing helped them, but that will be a one-man study. Most of the things that we use as definites in terms of this is how this works, this is what we'll use to treat you, are things that have been studied in multiple people and we have seen results. So unfortunately for soursop, for some African herbs, there's quite a number of them that people have been talking about. We need more studies, so I can't recommend it.
Mhm. Yeah, thank you. And thank you for being open and honest about that as well, because I think it is really important people to hear it. So just a bit more questions are coming through just about the treatment. And one of the things was about the surgery. So someone said that they've heard the radical surgery can be complicated by erectile dysfunction, and that then tends to moderate kind of the health-seeking behavior of people who are getting symptoms. So could you, so the person said, you know, how true is this? And it would be great to hear your reflections about it.
Right. So I think I would still go back to saying early diagnosis makes loads of difference, because you can imagine that there's something bad in the whole of the prostate, but it's in one tiny place. It means that if we're taking out the prostate, we don't have to affect things around. In fact, in London, they've started doing focused therapy just for that small area. So they're not going to have erectile dysfunction with that. So the earlier you come, the more amenable it is to less radical things. Now, if it is a radical prostatectomy, because I think that's what the question is about. If it's a radical prostatectomy, yes, there is a risk of erectile dysfunction. Remember those nerves I put in the presentation? So they're just at the back, but at the side. Now, if we have an MRI, we know where the cancer is, and we can say this is away from those nerves. So what we can do is we can separate the nerves and leave them to reduce the risk of erectile dysfunction. But by the time it's a late presentation and it's involving those nerves, that's when we're not so confident to leave those nerves behind, because truly it's survival over erection, even though some people might think of it the other way around. So an early presentation gives us more options in terms of preserving the erections. Now, even if there is one side involved, we try to leave the other nerves intact just to help with that. And then we are quite aggressive about what we call penile rehabilitation therapy. So we've got cancer specialist nurses, wonderful team. They work with the patients. They give them vacuum devices. There are so many options that they can use to make sure the erections are adequate. Okay. And then it's like a 6-week intensive course of erection exercise, let me just say that, to make sure that the surgery doesn't affect too badly. However, yes, it is a known risk and we counsel about it, but where we can avoid it, we do. Then I have to say something. In late presentation of prostate cancer, erectile dysfunction is already there because the cancer is invading those nerves. So I've seen patients that just come to me with erectile dysfunction. And by the time you examine them, you see that it's a malignant prostate that is really in the late stages. So yes, the treatment can cause it. The disease can cause erectile dysfunction. So not having the treatment doesn't mean that erection will be preserved. And also, as men grow older, their erections get less. So there are multiple things that can affect erection. So don't let your cancer go haywire while trying to protect an erection when other things are affecting it anyway.
Thank you. Thank you so much. And just thank you for taking the time to explain that, because someone else has just written thank you, and my father needed to hear that answer. So yeah, really, really important. And I think another question that has come through, and I've heard this question asked a number of times, is about sexual preference. And is that a factor, i.e. heterosexual versus someone that is bisexual, or is that, or has sex with men exclusively? Is there not enough studies about that, or do we see that that's a relevant factor in the acquisition of and development of prostate cancer?
No. So in terms of cancers, heterosexual activity has been linked to anal cancer, and that is human papillomavirus related, not prostate cancer. No.
Great. Thank you so much. And again, just because we've so rightly been focusing on the screening as well and early detection. So just to clarify, some people have asked, how often do you have to be checked? And is it like a smear test, every 3 to 5 years, or?
Right. I had that slide, but I thought it was getting a bit complicated, so I let it slide. So and then you can see what I'm talking about.
Oh, lovely. As I said, I love it, because those everyone that listens on here, they ask fantastic questions and get to the nugget of it. So yeah.
This is what came out this year for the EAU. Now that's the European Association of Urology. So they kind of had an algorithm which is not yet adopted by everybody, which is why I tried not to emphasize it. But their algorithm is that if by the time someone is 40 and their PSA is less than 1, then their recommendation is come back in 8 years. But the issue with that is these studies are not just, this is everybody. This is whites, this is blacks, this is Asians. So we don't have enough studies just for Black people who have a higher risk. They say if the PSA is less than 1.5, repeat it in 5 years. If it's in this range, do it every 2 years. And of course, we said everybody that is here gets referred to us anyway. So I would say, if you're 45, get it annually, Black person, and just work from there. I think that's the safer thing to do. But these are the guidelines, and a lot of times the GP might refer to something. We have nice guidelines. We have the GIRF guidelines. So they will refer to something, but this who has proposed. But like I say, this is not for just Black people. So above 45, you're Black, you have a strong family history. Most of the time we'll say, check it every year. The guidelines will also guide the GP as to whether or not he will do it. Yeah. But presents, type 1 delays. Don't let that be the reason. Type 2, they can't get there because the roads are bad in sub-Saharan or something like that. Type 3, it's the system that mitigates against it for different reasons. Don't let it be a type 1 delay. Present. Okay. All right. I will stop sharing this.
No, perfect. No, present.
Yes.
And someone's asked a question, and I just to highlight as well, because someone said, sorry if I'm drawing you back, and you're not at all. And we encourage people, because we know when listening to a presentation, you pick some bits and then you forget another bit as you go on. So this is exactly why we have the question and answer session, just to clarify and to reinforce. So please, thank you for drawing us back and asking this. So someone's just asked, what are the available treatments for prostate enlargement?
Right. So that's a broader term. I hope I've stopped sharing the slide.
I think you still are on my screen, but
okay. Okay, I'll keep talking anyway.
Yeah, no problem at all.
That's a bigger question, because we're talking about prostate enlargement, not necessarily prostate cancer. So like I said, prostate enlargement, there are things can cause prostate enlargement. So if we're talking about the benign, I don't know if the person is on.
Just temporarily there. Hopefully her internet connection will come back soon.
I can hear you. Can you hear me?
Yeah. Let's see if we can.
Hello.
We can hear you okay, Dr. Vanessa, but it appears that Dr.
Oh yeah. So I thought it was me. Obviously, being in Ghana, I blame it here.
Did that freeze for you as well?
Sorry?
Did Dr. Ijeoma not freeze for you as well?
She did, but you can never tell. So I never quite trust it here. So I'm always like, oh, it's probably me. So yeah.
Okay, well, maybe if we can.
She's in the waiting room. Let me just add her now.
Oh, there we go.
So let's see.
Yeah, so she's joining now.
Sorry, everybody. You know, technology isn't always reliable.
I know. As I say, I'm really surprised it wasn't me. So there we go. I did a quick internet change just to check. So yeah.
Dr. James, okay? Have you been able to rejoin the call okay? Let me see.
We'll give him. There was only one more question that we really needed to go through. So
Benedict, do you mind making her a co-host again, please? So that she can unmute.
You could be a co-host now.
Thank you so much. Okay. Dr. Ijeoma, hopefully.
And technology takes over again.
I know, but we I was saying that I actually thought it was me being in Ghana, so I did a quick internet change. So no problem at all.
Okay. So the person was asking about treatment for enlargement. I can quickly say it. So if it's benign disease, we have loads of options. For really small prostates, less than 30 cc. When I say 30 cc, 30 grams, we're talking about, you could just do lifestyle sometimes. So it might just be that you're taking a lot of caffeine and that's making you need to go wee a lot, and maybe that's all you need. Or you could have some medication first that can reduce the prostate volume or relax it a bit. And then, of course, if there's failed medical therapy or reasons for surgical intervention, we move on to surgery. And those could be, there's a new, well, not really new anymore. We call it a urolift. We can use staples to take the prostate away from the urinary tract. So normally it encroaches into the urinary tract, so we kind of staple it away. So that's a urolift. Sometimes we use steam to cause necrosis of it, so it sloughs off and then opens up. And then there are some less, for smaller ones, iTinned, there are loads of things. In sub-Saharan Africa, we do some open prostatectomies. We also do endoscopic treatments. So with the transurethral resection of the prostate, where it's a scrape of the prostate out of the waterworks so that it opens up the channel again. For larger prostates, we now go into bigger things. So we could have a holmium laser enucleation. So where we core out, you remember that picture I showed you? So that benign bit, we core it all out. Same thing that you would have done with an open, but now it's all endoscopic. And we have aquablation. There's so many options for a benign prostate enlargement, so many options. And if it is an enlargement with cancer, the surgeries will be the minimally invasive, like I mentioned, the high-intensity focused ultrasound scan, or the robotic radical prostatectomy. Some people do it laparoscopically. but those are options for the prostate cancer surgeries.
Great. Thank you. Thank you. And thank you for persevering as well with the internet as well. And we've got one last question, and it really feeds on into why we're here, just to kind of clarify some of the myths and and clarifying what people hear from healthcare professionals as well. And someone's just commented, which I think is great to tie it in, is that this information that you're giving really highlights the importance of family health conversations, so that people will be proactive together. So thank you, whoever commented on that. I think that's so important, and that's what we encourage with these health hours. So just with this question,
can I say something about that
please.
comment? I think that is so important, especially about the Black men. I know a lot of them are macho and have this impression that nothing can go wrong with them, and they don't want to talk about their nether bits or struggles with those things. So it is a taboo topic in a lot of places. So please, yes, family talks are important, but men also speak up. Please speak up. Don't hide things. Speak up. Get things checked, okay? It's not a stigma. It's not a shameful thing. Get things checked, please.
Perfect. Thank you so much.
Somebody has said,
I know. I just
said,
wives, book your husband for the test. I love it. I love it. Oh dear. And so, for the question that I was leading on to is that someone said, look, I'm sure that my husband's GP tried to tell him that taking the test was a false sense of security, as it might show a negative test, but then you might develop it later. So it would be great if you could kind of put this into context, and, disclaimer, we are not here to critique anyone's explanation or care. It's just to kind of explain the kind of wider context of why a comment like that may have been made, I think.
So I'm going to take you a little bit back, because there are a lot of things that are said and need to be taken in context. Now, before a PSA test is offered to anyone, the GP will tell you the risks of doing it, so that you don't just keep having it done. So they'll always tell you that you do know that this can lead to many other things, and sometimes it's inappropriate for you. They will tell you that. For example, we mentioned somebody who has less than 10 years to live, and doing that in an 80-something-year-old person who has a poor performance status, they might not offer you a PSA screening. That's one. So everything is taken in context. And what the GP is saying, from what I'm gathering from this conversation, is doing it and having a 0.5 does not mean that 2 years' time it will not be a 10. So basically, that person is saying it's not a one-off thing. So even if you do it now and it is normal, it does not mean that in future you may not have it. So I think that's what they're saying. And they have to let you know that there are pros and cons of doing it. It is their duty. And that's what the guidelines say. Before offering anybody a PSA test, tell them of the pros and the cons. That's the standard practice.
Perfect. Thank you so much. I just want to say a huge thank you to you for such a clear and really powerful presentation, and very reflective of the fact that we've had so many questions come through and people being really engaged. And I want to thank everyone that's been listening and engaging, just to kind of bring this conversation more to our day-to-day life and how it can impact our family and friends. So just, in the words of someone who commented there, and Miss Ijeoma, please, please, please present. Come and get screened. early diagnosis saves, and have those family conversations, really have them. But also men out there, and please tell the men in our lives, in our networks, to please come and present themselves. So just saying a huge thank you so much for everyone. Thank you, thank you.
Thank
And
you.
now I'm just going to hand over to Shola, who is going to give us some highlights of what's going to be happening in the week to come. Thank you so much.
Thank
so
you.
much.
Bye.
Right. Thank you, everyone. If you can hear me, I'm just going to be sharing my screen quickly with a slide. I want to say thank you to both Dr. Vanessa and Ijeoma as well for taking us through that I'll say powerful presentation. Thank you very much. Great. I don't know if you can see my screen. Yes.
It's just loading, I think, Shola, but we should
Yeah,
hope.
coming.
Okay, good.
Thank you.
Hopefully now.
It says double click enter. Okay, yeah, perfect. Yeah, we can see them now.
Is it good?
Yeah, if you can put it on full screen, please. Thank you.
Okay. Just give me a second. Right. I'm trying to get to the beginning of the slide. Apologies. Right. Thank you very much for joining us today on a very important topic, which is about prostate cancer. And I want to thank again Dr. Ijeoma and Vanessa for facilitating the session today. So just as we've done today, we do have our health hours happen every Saturday, and our next health hour is going to be on the 14th of December 2024. The start time is at 11 o'clock, and it's for an hour between the hours of 11 and 12 o'clock. So we hope to see you next week as well for another engaging topic of conversation around our health and the Black community. Also, we understand that it's, the festive season, so Khan and some of our partners have been putting together some festive events for people within Manchester and beyond. So we've got our Moms and Kids Xmas Pamper Day happening next week, Saturday, between 12 and 4 p.m. at TCRC, Transformation Community Resource Center in Longside. If you're ready for some beauty prizes, limited gifts, music and dance, snacks and drinks, please do send an email to scholastic@can.org.uk, which we have on screen right now. Also, you're welcome to join us for our Greater Manchester Caribbean and African Community Carol service taking place on Wednesday, the 11th of December at 7 p.m. at the Manchester Cathedral. Experience Joy of Christmas with community choirs, an orchestra, candlelight reading, refreshments, and more. It's free entry, and if you have any questions, please contact events@can.org.uk, or you can call the number on the screen 077 10 382. We also understand that during the festive seasons is when a lot of people might feel anxious and isolated about certain things. So if you're stressed about energy bills and you need somebody to confide or talk to, we have a partnership with Shout UK, which offers 24/7 free confidential text support with a trained mental health advisor. So please text if you're in need of this service. Text WARMTH, that's WARMTH, to 85258 for free confidential support 24/7. We have this in partnership with Cadent Gas Network. We also run diabetes. One of our partners, not Manchester Partnership, runs a diabetes peer-to-peer support. So if you're somebody that is in need of this service, please do not hesitate to call 0777-499-4178. And if you've got any question about this diabetes peer-to-peer support, please you can email info@can.org.uk for any questions you might have. If you're in need or you think you want some counseling done, we do offer a Black-led counseling service within CAN. So if you're dealing with things such as bereavement, grief and loss, mental health, you need some family support, anything that's to do with domestic violence, or just counseling in general, please do not hesitate to get in touch with us. And that's at counseling@can.org.uk, or you can give a call to 077 1002 2382 for you to speak to somebody from our counseling team. Corona Qualities UK are working on improving resources for Caribbean and African communities. If you have inflammatory bowel disease, there is a survey, or you care for somebody that's got inflammatory bowel disease, there's a survey that is going on at the moment, and the survey closes on the 6th of December, which was yesterday actually. If you have any question about this survey, please do email research@can.org.uk to see if you might be able to participate. I mean, I do understand that the time for the survey is over now, but if you've got any questions at all, please do not hesitate to contact research@can.org.uk. If you know anybody with inflammatory bowel disease, or you are living with one yourself. And that's it for today. We really want to thank you for joining us on today's Health Hour session. We hope to see you next week. Thank you very much. Over to you.
Welcome to our Caribbean and African Targeted Health Improvement Program, CAFIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@can.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CAFIP is funded by the National Lottery Community Fund.